Anatomy and its variation for fess. Introduction. If the ethmoid were placed in any other part of the body, it would be an insignificant and harmless collection of bony cells. In the place where nature has put it, it has major relationships so that diseases and surgery of the labyrinth often leads to tragedy. Any surgery in this region should be simple but has proven one of the easiest ways to kill a patient. Mosher 1929. It is of utmost importance to master the relevant anatomy and its variations before one embarks upon endoscopic sinus surgery. Osteomedal unit. It refers to the common drainage pathway of the anterior sinuses, frontal, maxillary, anterior and middle ethmoid sinuses. The osteomedal unit in the center of interest in the lateral wall of the nose since the development of fess, since it is thought to be the key in the pathogenesis of chronic sinusitis. OMU is comprised of ethmoid infundibulum, uncinate process, ethmoid bulla, hiatus semilinaris, middle meatus, nasal septum. Commonest variation seen is a DNS. Variations like septal pneumatization can be picked up only on CT scan of nose and paranasal sinuses. Inferior turbinate. Inferior turbinate hypertrophy (ITH) can be a compensatory process or an infectious pathology. A preoperative preparation with steroid nasal spray and decongestants helps to reduce the inflammation. Inferior turbinate pneumatization is very rare and, if present, will grossly obstruct the nasal airway. Middle turbinate and middle meatus. Middle turbinate ethmoid bone overlying the middle meatus is the most important anatomic area in the lateral wall of the nose. Superiorly, it is attached to lateral aspect of the cribriform plate, between cribriform plate and fovea ethmoidalis. Its lateral attachment, called the basal lamella, attaches to the thin lamina papyracea of the lateral ethmoidal wall. Posteriorly, the basal lamella curves superiorly to become coronally orientated. This coronal part separates the anterior from the posterior ethmoidal air cells drainage to the middle meatus. 1. Bulla ethmoidalis, a prominent anterior ethmoid air cell, located posteriorly in the middle meatus, receives drainage from anterior group of ethmoid air cells and drain into ethmoid infundibulum, middle meatus. 2. Hiatus semilinaris, just inferior to bulla ethmoidalis. Anteriorly, it receives drainage from anterior ethmoidal air cells. Posteriorly, it receives drainage of the maxillary sinus via the maxillary sinus ostium. 3. Frontal recess nasofrontal duct, defined as bony walls that lead to and communicate with frontal sinus. Frontal sinus drains via frontal recess and nasofrontal duct into middle meatus. Pneumatization of the middle turbinate occurs as a normal variant and is called concha bullosa. Concha bullosa is abnormal pneumatization of middle turbinate which may block the infundibulum and may lead to sinus disease due to defective aeration of the sinuses. Paradoxical middle turbinate is the abnormal curvature of MT, where the convex surface faces laterally and may block the drainage pathway of middle meatus. Other variations of MT which were recorded intraoperatively by Gupta et al. Were duplicate MT in 2, 1.44%. Multilobulated MT in 1, 0.72%, accessory MT in 1, 0.72%, and bifid MT in 1, 0.72% case. Superior turbinate. It is the smallest turbinate which overlays the superior meatus. Posterior ethmoidal air cells drain into superior meatus via multiple ostia. Sphenoethmoidal recess lies on posterosuperior aspect of superior turbinate between the anterior wall of the sphenoid sinus and the posterior wall of the ethmoid air cells. Sphenoethmoidal recess drains the sphenoid sinus through the sphenoid ostium. Ethmoidal infundibulum. It is cleft like 3D space in the lateral wall of the nose, bounded medially by the uncinate process, laterally by the lamina papyracea and frontal process of maxilla, and posteriorly by the anterior surface of the ethmoidal bulla. It becomes atelectatic if there is paradoxical middle turbinate, concha bullosa, or if the uncinate process is butting against the lamina papyracea. Uncinate process. It is a thin, sickle or L-shaped bone resembling a bent hook or a boomerang. Its ascending convex anterior margin merges with the lateral nasal wall, whereas the posterior margin is sharp, free and concave. Attachment of uncinate process is known to have a bearing on the drainage of frontal sinus. If it is attached to lamina papyracea, frontal sinus drains medial to up, but if It is attached to skull base or MT, then sinus drains into infundibulum just lateral to up. One should be aware of presence of accessory ostium because during surgery, if the natural and accessory ostia are not joined, then it can lead to recirculation phenomenon with persistent symptoms. Hiatus semilinaris superior. This is also a crescent-shaped cleft between basal lamella and the posterior wall of bulla ethmoidalis. It is through this gap that the sinus lateralis, when present retrobullar and suprabullar recesses can be entered inferomedially. Underneath the middle turbinate, lateral sinus, sinus lateralis of Grunwald. It is bounded laterally, lamina papyracea, superiorly, ethmoid roof, posteriorly, ground lamella, anterior and inferior, roof and posterior wall of ethmoids. Anterior ethmoidal artery. Anterior ethmoidal artery, AEA, is located in roof of anterior ethmoids posterior to frontal recess and may lie in a bony canal or in a bony mesentery. It can be visualized on coronal sections on CT scan where it forms medial beak of supraomedial orbital wall as it branches out from ophthalmic artery. Surgical significance. The weakest point of the entire skull base is the point at which the AEA leaves the ethmoid and proceeds anteriorly in the ethmoidal sulcus of the olfactory fossa. Greatest caution must be exercised while working medial to the ethmoid roof. Knowledge of course of AEA is very important for surgeon. If injured during surgery, it gets retracted into the orbit causing orbital hematoma and subsequent visual loss, if not treated immediately. So, surgeon must be familiar with the possibility of an abnormal course of AEA. Identification. Follow the anterior surface of the bulla in the direction of the roof. The artery is 1 to 2 mm posterior to their confluence. If the anterior bulla lamina does not extend up to the roof and there is no separation between the frontal recess and lateral sinus, the artery is seen in the lateral sinus. Haller cells, infraorbital ethmoid air cell. Haller cells develop in the floor of the orbit, adjacent and above the maxillary ostium. When enlarged, constrict the infundibulum and blocks the maxillary sinus ostium. Olfactory fossa. Frontal bone lamellae are much thicker than ethmoid lamellae. Frontal bone abuts against the lateral lamella of lamina cribrosa, constituting the lateral border of olfactory fossa, which can vary. Highest point of the roof of the ethmoid can be as much as 17 mm higher than the lamina cribrosa. Quiros has described 3 types of olfactory fossa, depending on the depth. Type 1, 1 to 3 mm. Type 2, 4 to 7 mm and Type 3, greater than 8 mm. 0.10. More is the depth, more are the chances of injury to skull base during endoscopic sinus surgery. The lateral lamella is particularly vulnerable, where the olfactory fossa is deep. The cribriform plate. Anterior cranial perforation with CSF leak may occur, if the surgeon is not aware of low ethmoid roof or excessive sloping of the roof. Anode cell. The posterior ethmoid cells may extend into sphenoid sinus and may surround the optic nerve. These cells are called anode cells. Their presence may increase the chances of optic nerve injury. Surgical importance. Posterior cells can develop laterally or superiorly, anode cell, over the sphenoid sinus. Laterally, these may lie up to 1.5 cm beyond the sphenoid sinus. In the presence of an anode cell, the anterior wall of sphenoid runs from anteromedial to posterolateral instead of frontally, so the direction of dissection must always be inferomedial after perforation of the ground lamella. Generally, in presence of anode cell, optic nerve passes through the cell but not always, as reported by Gupta et al. A preoperative knowledge of attachment of sphenoid septa can reduce complications as they can be attached to optic nerve or carotid artery. In a study by Gupta et al., 3% of intrasphenoid septa were found to be attached to optic nerve, and 2% were found to be attached to carotid artery. Sphenoid sinus. It is the most posterior of the paranasal sinuses, lying superior to nasopharynx, anterior and inferior sella, having variable pneumatization with inverse relationship between pneumatization and the thickness of the sinus wall. Sphenoid pneumatization can be as follows: A. Concal, 5%. B. Precellar, 23%. C. Postcellar, 67%. Anterior face of the sphenoid lies approximately 7 cm from nasal sill on 30 degrees axis from the horizontal. Relationships of important structures. Superior. Hypophysis, olfactory tract, Frontal lobe. Inferior. Nasopharynx, Vidian nerve. Lateral. Cavernous sinus, carotid, cranial nerves 2, 3, 4, 5, 6. Posterior. Pons, basilar artery, Fig. 10. Sphenoid sinus variations. Optic nerve. Delano, Fun and Zinreich classification. Type description. 1. Adjacent to sphenoid sinus. 2. Indentation on sphenoid sinus. 3. Optic nerve traversing sphenoid sinus. 4. Adjacent to sphenoid and posterior ethmoid sinuses. There may be multiseptate sphenoid sinus. Complete clearance of disease from all compartments is a must to prevent residual disease. There may be excessive pneumatization of the pterygoid processes. Dehiscent carotid artery was seen in 10.2% sides, and dehiscent optic nerve in 18.2%. By Joseph Keynes et al. 0.14a study by Sheetal et al. Noticed dehiscence in both structures in 2% cases. Dehiscent carotid artery and optic nerve increase the chances of complications during surgery. Frontal sinus. Frontal sinus develops from small grooves in the cartilage of the lateral nasal wall during the 3rd and 4th fetal month and is incompletely developed at birth. It is first visible radiographically in patients aged 6 years. The frontal sinus opens into the frontal recess or directly into the anterior end of the infundibulum. Anatomic boundaries of frontal recess. Anterior, uncinate process and agar nasi. Posterior, bulla ethmoidalis and suprabular lamella. Lateral, lamina papyracea. Medially, hiatus semilinaris or middle turbinate. Inferior, ethmoid infundibulum. Superior, fovea ethmoidalis, supraorbital cell, AEAN. Frontal ostium. Frontal cells. Presence of various types of frontal cells. Kuhn cells may change the drainage pathway of frontal sinus. They should be studied in detail on CT scan preoperatively, and all cells must be opened during surgery to achieve an adequate frontal sinusotomy and for complete removal of disease. The Kuhn classification of frontoethmoid cells. Kuhn type 1 K1 cell, single cell above an agar nasi cell. Kuhn type 2 K2 cell, 2 or more cells above and directly behind an agar nasi cell. Kuhn type 3 K3 cell, single large cell above an agar nasi cell, pneumatized into the frontal sinus, less than 50%. The height of the frontal sinus. Kuhn type 4 K4 cell, single large cell above an agar nasi cell, pneumatized into the frontal sinus, greater than 50% the height of the frontal sinus. Modified Kuhn classification of frontal ethmoidal cells. Agar nasi cell, supraorbital ethmoid cells, frontoethmoidal cells. Type 1. Single frontal recess cell above agar nasi cell. Type 2. Tier of cells in frontal recess above agar nasi cell. Type 3. Single massive cell pneumatizing cephalad into frontal sinus. Type 4. Modified from original classification A cell, pneumatizing through into the frontal sinus and extending greater than 50% of the vertical height of the frontal sinus. 7, 8. Frontal bulla cells, suprabulla cells, interfrontal sinus septal cell or intersinus septal cell. With increasing horizon of sinus surgery where more of optic nerve and anterior and middle cranial fossa lesions are being dealt with endoscopically, surgeon needs to be more familiar with various variations in the anatomy of the important structures, as even a small mistake can be detrimental to the vision and life of the patient. So, an in-depth and thorough knowledge of the anatomy with its variations is essential for endoscopic sinus surgery, and the best way for this is cadaver dissection training and attending endoscopic sinus surgery workshops.